Lovely. Well, thanks very much, Bella, for the introduction. And it's just a real pleasure as well to follow one of our amazing MSc Global Health graduates. So, Mireille, thank you so much for your talk. And it's lovely to be back in touch with you again. So, as Bella says, I'm going to look at tackling inequities in global health through the lens of one particular condition that I've been studying for around 20 years now. And I'm going to take this approach, a very brief description of this unusual condition, because I realise that many people won't have heard of it and won't know much about it at all. So I'm going to just explain enough so that you can understand, if you like, the rest of the story. Then I'm going to go a little deeper and explain how inequities produce, sustain, and arise out of podoconiosis. And then to finish on a sort of brighter note, given the aim of World Health Day is to try to look for the positives despite inequities, I'm going to concentrate on what can be done. So I've shown a picture here of somebody whose feet and lower legs are affected by podoconiosis. This is a non-infectious condition which is characterised by steadily progressive swelling that rises up the leg from the foot towards the knee. It's, if you like, the lesser known form of lymphedema in the tropics, the better known form of lymphedema or leg swelling being that caused by lymphatic filariasis. In many countries, it's confused for lymphatic filariasis. And so a lot of our work has been about unravelling the causes of lymphedema in certain countries. And it's a kind of complicated condition. There's no parasite, virus, bacterium, or fungus directly involved, but it seems to be a condition caused by the combination of genetic susceptibility, environment, and behaviour. And I'll explain that a little bit more in the next slide. If you're interested to find out more about this condition, there's a training course hosted by WHO, actually now in the academy. And this is available in, I think, about 5 different languages now. And you could get a sort of better understanding of the condition and what's being done about it at your leisure through that course. Let me explain a little bit more about the etiology, because this it's important to understand this, to understand how inequities also shape its occurrence. So we have this combination of a background of genetic susceptibility, and that middle figure shows a family pedigree indicating those within the family who have podoconiosis with a top red upper quadrant, and shows that it's across many generations in that family. And although it's predominantly seems to be in men in that particular family, it's also found in the paternal grandmother of the proband. So it's not an X-linked disease. What we understand is that somebody whose sibling is affected by podoconiosis has a 5 times greater risk of developing it than a person whose sibling is not affected. So there's a high heritability present in the condition. But susceptibility is not the same as determinism. So just because you have susceptibility doesn't mean that you have to get podoconiosis, because in addition, you need exposure to particular irritant soils commonly found in the tropical highlands. Now, we don't yet know what it is within the soil that's triggering podoconiosis, but a number of mapping techniques have shown that it is certain soils formed under certain climatic conditions that seem to be related to triggering podo. And then, of course, even if you have susceptibility and live on an area of irritant soil, there is still the final factor, which is long-term exposure to that soil. And it seems that about a decade of exposure is necessary. So this third piece is very, very important in considering inequities, because it's people who go barefoot and who have little access to water to wash their feet that are going to be particularly vulnerable to podoconiosis if they have the genetic susceptibility. So let's track through how inequities can produce podoconiosis. As I've said, it is a condition of very remote highland communities in areas of ancient volcanism, which are the conditions that seem to be required to generate the irritant soil. So these communities are very often very remote from capitals, places with good health facilities, or places where voices can be heard, if you like. The picture shows a very typical highland area in northern Ethiopia, very fertile, beautiful crops growing there, but also the soil is a trigger for podo, and so this is a heavily endemic area. It's about a 6-hour drive from the capital to the nearest district town, and then a further 2 hours drive up towards these highland areas. So these are very remote communities often. And particularly vulnerable to podo are subsistent farmers who are working the land. They may be men or women, and they're involved in agriculture day in, day out. These are people who can't regularly wash their feet and legs. Water is often very precious, particularly seasonally, and so the priority will often be to use the water for cooking, for drinking, and possibly washing their hands, but rarely the feet and legs. And finally, these are very often people who cannot afford or access suitable footwear, and there's been a lot of work around this. And so even in communities where people would buy shoes and could buy shoes, they often cannot access suitable footwear to protect their feet from the soil. Inequities also sustain podoconiosis. The condition has been really ignored historically, meaning there's a lack of policy and programs in many endemic countries. As I mentioned before, it's often misunderstood, and that's by health professionals and by the affected communities. By health professionals who may think it's the other type of lymphedema, that caused by lymphatic filariasis, and by communities who may often have other understandings of the reasons that people are affected. These may be supernatural. The condition disables and often will lead to difficulties in accessing healthcare, which may be very distant. And people in these communities are often having to walk very long distances to attend healthcare, and the walking itself actually worsens the condition, a sort of vicious cycle there. And podoconiosis has been shown by many researchers to bear a large amount of stigma, and this may come out in terms of reluctance to attend healthcare facilities where historically people have been further stigmatized by health professionals. And lastly, inequities arise from podoconiosis as well. Consequences include lower levels of school attendance, whether that's by people affected themselves or the school-age relatives of people affected who may be involved in caring for their parent or elder. There are increased levels of depression and suicidality. There's a severe impact on ability to work and thus on income. And catastrophic health expenditure can occur in affected families, which of course leads in turn to many consequences, including the inability to afford suitable footwear. So as you can see, there's this cycle going on. So podo arises from inequities, produces further inequities and sustains them. And on the other hand, inequities produce, sustain, and arise from podo. What can be done? So over the past 20 years, our research has led to identification and mapping of podo across 5 endemic countries. And there are at least another 10 that really need further investigation and possible full mapping. We have improved, though far from complete, understanding of the genetic and environmental causes. There's been deep exploration of local understandings of the condition and its psychological and economic consequences. There have been trials of frugal and resource-appropriate treatments and of how to get holistic care integrated into countries' health systems. And there's been local, national and global advocacy through footwork, and the website is there, putting out messages that podoconiosis exists and that it can be eliminated. We understand that a simple focus on healthcare is insufficient. We need to take a variety of approaches, including that of human rights, a development perspective, a women-focused perspective, and one that understands the impact on children as well. And meshing podo elimination with universal health coverage is also a very important way of framing the condition. So lastly, this is a sort of timeline of how advocacy has continued for podo, from WHO naming it another neglected condition and the launch of NAPAN and footwork, to prioritisation, a first international podo conference, a fact sheet available, the open course that I mentioned. We've recently had our second international podo conference in Kigali. That was in January. And just 2 weeks ago, in March, there was a side meeting at which formation of an Afro-regional elimination programme for podoconiosis was approved. So I'll leave it there, and I'm very happy to take questions from anybody, I think, after all 4 presentations have been given. Thanks very much.